Hello, my name's Ken Kinter. I'm an assistant professor at Rutgers University, and welcome to this presentation, which is part one of a two-parter on readmission at state psychiatric hospitals. I would recommend, if you haven't seen the video on psychiatric hospitals yet, I would start with that one, but that part's up to you. So as always, all feedback is encouraged, and if you like what you hear, go tell somebody. Now, the project I work for is called SPRE, the State Hospital Psychiatric Rehabilitation Initiative, which is an effort to improve the quality of care and working conditions at New Jersey state psychiatric hospitals. We simply couldn't do it without the financial and other support of the New Jersey Department of Health, so we will give credit where credit is due. The objectives for this presentation are to introduce and discuss psychiatric readmissions, explain why they are as complex and problematic as they are, particularly to state psychiatric hospitals. We're going to talk about the study of readmissions, specifically the readmit scale, and my own work, which is stemming off of the readmit scale and which is ongoing. The second part will be where we get all of the results. So let's start by talking about readmissions. And hopefully this is something you've not experienced firsthand, but it's when you have to return to a facility like a medical facility, psychiatric facility, or addiction treatment center for a similar or related reason. These are concerns in all inpatient settings, and they are not necessarily a bad thing. There are people that need help again shortly after receiving help the first time. Where it gets a little more complicated for psychiatric facilities is with deinstitutionalization, the shortening of length of stays, there have been an increase in readmissions. And what we're really concerned about is the preventable readmissions. How many of these can we head off and keep these down for reasons that we will discuss coming up? Readmissions are not a reliable indicator of the quality of a facility, as we will discuss. However, hospitals are being penalized under the Affordable Care Act for having higher readmission rates, specifically 30-day readmission rates. Now, one of the points I'm going to be really leaning on in this video is that readmissions are a product of many different domains. One domain is the actual person or patient. One is the treatment within that specific facility. And another one is the aftercare or placement that the hospital refers the person to afterwards. So regarding readmissions, specifically state hospital readmissions, the average is about 1 in 7 people within 30 days. And 30-day readmissions gets the most study. 6 months and 1 year also get evaluation, as well as lifetime. But 30 days is the one that people really look at. And 1 out of 2 people are readmitted within a year to a state psychiatric facility. And this prompts the talk about the revolving door of the mental health system. This is actually a picture of the revolving door from the baptism scene in The Godfather. You'll see a few movie references in here. The impact of psychiatric readmissions is devastating and multidimensional. First of all, if you've ever had the experience before, going in the hospital, going out of the hospital, going back in the hospital is really difficult on a person. It has financial problems. It may affect where somebody lives. You're not able to pay your bills. You're just disconnected from your life when you're in a hospital to a certain degree. It's also really difficult for families. Is my loved one in the hospital? Is my loved one okay? Are they out of the hospital? And this back and forth. It's very difficult for hospitals. It's a lot of work to get someone out of a hospital and to process someone back into a hospital. And it's unnecessary. It feels like a hole in the bottom of the boat to a certain degree. It's also very difficult on community services because when you get a referral, there's a lot of work in that front end. Again, it's very stop and start. And as we'll discuss, these services are underfunded to begin with. They don't need this. It's also devastating on budgets. All of this work that we're talking about and this lost productivity on the part of the person or families all has financial undertones as well as the emotional impact. So as we were discussing before, readmissions to state psychiatric hospitals have a couple different domains to them. The first domain is people. The actual person or patient themselves is someone with a severe and persistent mental illness, often with an addiction as well, and you're catching them at their most ill, in fact, potentially dangerous if they're being committed involuntarily. Most of the people in this category are uninsured or underinsured, so they don't have access to all the healthcare services that someone might have that has third-party insurance. There may be homelessness issues. There may be issues regarding documentation and about legal issues, and those also restrict the number of places that person can get services. The hospitals themselves, historically, they've been large and over capacity. They're remote from where the patients and the families live, so you're disconnected from your supports. They are also state-run and unionized. That's not necessarily a bad thing, but it's more people at the table. And as my colleagues Smith and Bartholomew have shown in their article, Can Hospitals Recover? These hospitals are very slow to change. Crisis changes them. So they haven't necessarily been responsive to the changes in their population or to the system. The third domain is placement or aftercare. Where is this person going to live and where are they going to get their follow-up care from? These places are very often overwhelmed, underfunded, and have availability problems. There's simply more demand than there is supply. And it's been that way through all of deinstitutionalization. So I took the research that goes back to the 70s on readmission, specifically 30-day readmission, just to see what it would look like in sort of a visual form. And you can see a couple things jump out here. Age jumps out, diagnosis jumps out, marital status, legal status jump out. So this is what it looks like in front. There are as many as 67, the last that I saw, different factors that come into play when you're talking about 30-day readmission. Now, initially, back in the 70s, when they started studying readmission, they were primarily focusing on the person or the patient themselves. Was it about them? Then over time, it started to become a little more holistic, looking also at the hospital, looking also at aftercare, looking at the environment. And the readmit index is a really profound effort to create a risk assessment. So how could we determine at the beginning if someone is at risk for 30-day readmission? So this looks at 20 different factors of the person, the hospital, and also their aftercare usage. And what happens is you end up with a scale going from 0 to 42, 0 being the lowest. They get readmitted 2% of the time. And the highest score, 42, the person readmits 49% of the time. So if you look at the bottom here, this isn't complete, but this is just the top end. These are the things that actually gave you the most points, the factors that led most often to somebody being readmitted within 30 days. So the one that measures 8 points is if someone is age 18 to 24. So that's the highest one. 7 points is age 25 to 34, or 6 or more prior admissions. So theoretically, if someone is in that age bracket, 25 to 34, and they have 6 or more admissions, that gives them 14 points right there. Moving down at 6 points, it's age 35 to 44, 5 points, age 45 to 54, 3 to 5 prior admissions. So not quite as many, but that's still a factor. And 4 points is diagnosis of bipolar disorder or psychosis, or admission length of 14 days or less. So what we can derive from this is that factors that are pretty significant, age, particularly lower, the lower the age, the higher the readmission risk. The more prior readmissions they've had, the higher risk they are. And then you also have diagnostic aspects, and length of stay also comes into this. So the readmit index has been replicated. It's been shown to have moderate reliability. It's a great study. I've based my own doctoral work off of it. It's been replicated in other places as well. However, since it was created in Canada, the commitment laws are a little different in Canada than they are in the United States. In fact, in the United States, they vary from state to state. Canada also has socialized medicine, which means that it's a lot easier to do record keeping. You can have a record on a person's entire life in one database. In the US, it belongs to private companies. So you could have some information at this hospital, some information with this insurance company. And it's very hard to put all that data together and look at all of that at one time to make data-informed decisions. The readmit index also eliminated variables that it didn't see as significant. And all those variables that you leave out, there's possibility of an omitted variable bias. They all together might have a significant or sizable impact. The readmit index also relied on hospital scales. My experience working in the hospitals has been that hospital scales tend not to be very valid or very reliable. In fact, there tends to be a bias involved. If somebody's being discharged, it almost behooves you to make them look better than they may actually really present. So there's a capacity for bias there. So again, in my work, which is based on the readmit scale, so the fictitious Pine Valley Hospital, this is some numbers about what their discharges have been from 2009 to 2019. This dark line, this light line underneath is the 30-day readmissions. And then the red percentages are the percentages of 30-day readmissions. Now, remember what we were going back to before, the average is 14%. So as you can see, these numbers are quite low and actually dropping compared to that average. And the number of discharges has also come down too, despite some back and forth. So in my work, I did some of the same things that the other studies have done. I broke different variables out into client factors, hospital factors, and discharge factors. The client factors include demographic aspects such as age, marital status, race, and sex, as well as that person's history, their medical diagnoses, their psych diagnoses, previous admissions. There's also hospital factors. What unit were they discharged from? What was their level of function? Were they restrained? Were they transferred? Also discharge factors. Where did they go? What level of residence was it? Were they referred to ICMS or PACT or other services? And then even looking at specific residences and specific treatment centers so we can get an idea of the return rate from those places. If you add all these factors up, including the ones that I couldn't get, because again, it's hard to get 67 factors, right? Or more, you end up with the complete risk for 30-day psychiatric readmission. So again, the purpose of my study, like the readmit, is to create a risk index that will identify people at risk for 30-day readmission, to help us make data-driven decisions about programming and discharge and aftercare to help minimize that risk of readmission. We want to create a report card of placements in aftercare. You know, where are the care providers and the locations that we're getting people back from more and less so that we can make better decisions. We want to give credit where credit is due. If a hospital has lower numbers, to be acknowledged for that, much like they get punished for having the high ones, even though, as we know, the hospital isn't the sole reason for those numbers. My goal is also to replicate this study at neighboring state psychiatric hospitals to validate the study, and also to look at different time intervals. For example, are the same factors that keep someone out for a year the same as the 30-day readmits? Or do those factors change over the course of a year? Would also like to add to the body of research on readmissions and hopefully clarify some of the discrepancies. There's a lot of times in the research where something was found to be significant in one place and not in another, increased admissions in one place and decreased in another. So the more you get, hopefully there will be more clarity with time. So what my study is going to look like, it's about 6,500 discharges and 400 readmissions from the time from 2009 to 2019 to create a database, to run the data for 30-day readmissions to help create this risk index. And again, to replicate this at other hospitals and for different time intervals. And we're assessing the services as much as we're assessing the other domains to get a complete picture. So in summary, psychiatric readmissions are a consequence of shorter stays. They're not purely negative. However, there's a number of them that are preventable, and our goal is to prevent the preventable. Readmissions are very problematic. They are expensive and potentially traumatic and extremely expensive, and a huge burden as far as person power, you know, the labor of getting someone into a hospital and getting someone out again. Readmissions now have financial repercussions, as we've discussed, and hospitals are, I believe, being blamed for failures in other areas. The readmit scale is one of the best efforts to try to assess risk so that we can see what the risk is of that person returning in 30 days right at the beginning. It's been replicated, it's been worked on, and one of my goals is to make a version of it that is more useful in the US and specifically here. So this is where I got the information from for this presentation. The highlight at the bottom is another source of our videos. You can find these videos through putting my name into YouTube, or you can do it by doing sites.rutgers.edu. In fact, if you belong to an organization and they want a certificate for attendance, we can do that in the Rutgers site. You can take a post test and also get a certificate for attending the program. So I thank you for your time and look forward. I hope you catch another video soon. Take care.